So we are running a little bit late, but that's just because we have so many excellent talks, rich in content, and everyone is curious and has a lot of questions, so I think that's great. For the next talk, it'll be the first of chosen presentations from abstracts that were submitted by a range of scientists from the level of students to postdocs and beyond. And we had a committee for each section choose the the abstract that we would like a presentation for. This is the one chosen for neuroimaging. I recused myself from this process. It turns out to be that it is one of my students who was chosen. His name is Jack Rutland, and Jack is going to begin med school here at Sinai next year, and he has already produced a lot of interesting research, his own output, implemented many of his own ideas, has many conference publications and one co-authored journal publication already. He has implemented for the first time hippocampal subfield specific tractography in patients with epilepsy at 7 Tesla, and he will present that to you today. Jack?
Good morning, everyone. I'm going to take this opportunity to talk to you a little bit about some very interesting findings in our lab in the hippocampi of epilepsy subjects. So for those of you who aren't familiar with epilepsy, it is an extremely prevalent and costly neurological disease affecting approximately 1% of the population. For patients whose seizures cannot be controlled adequately with drug therapy, neurosurgical intervention, either surgical resection of epileptogenic tissue or laser ablation, is an established treatment course. MRI positive patients are considered patients who have some sort of abnormality or lesion that can be identified on pre-surgical imaging scans. And these patients have enhanced chance of successful neurosurgery. However, nearly a quarter of all epilepsy patients are considered to be MRI negative, and these patients do not have any abnormality or lesion that can be identified on pre-surgical imaging. And these patients are less likely to be considered candidates for neurosurgery, and when they do progress to neurosurgery, they experience inferior outcomes to MRI positive patients and may not achieve adequate seizure freedom. So interestingly, the MRI negative patients that do progress to neurosurgery can be effectively treated if intracranial monitoring using SEEG electrodes or subdural strips are able to localize the seizure onset zone. Additionally, there are cases where surgical resection of suspected epileptogenic tissue prompts retrospective analysis of the pre-surgical scans that yields some neuroimaging finding that was very subtle and not detected pre-surgically. So taken together, these findings suggest that our current clinical imaging techniques may not be sensitive enough to detect very subtle focal abnormalities in patients who have traditionally been considered MRI negative. And importantly, the absence of a visible lesion on pre-surgical imaging does not necessarily mean the absence of a focal epilepsy network. So ultra-high field MRI may hold the solution to some of these issues. 7 Tesla MRI has several advantages over lower field strengths of 1.5 and 3 Tesla, namely higher signal-to-noise ratio, increased resolution, and enhanced contrast. These advantages may allow us to detect certain neurobiomarkers of epilepsy that can't be detected at lower field strengths. And recent work from our lab and also other groups has reported subtle focal abnormalities that are detected using 7 Tesla that weren't detected using 1.5 or 3 Tesla. So to give you a little bit of background on the hippocampus, it's very well studied in the context of epilepsy. It's probably the most implicated brain structure when it comes to epilepsy, especially for medial temporal lobe epilepsy. And interestingly, recent ex vivo studies have suggested that the different subfields of the hippocampus participate in seizure activity in distinct ways. So the objective of this study was to perform hippocampal subfield-specific tractography within the hippocampus to try to quantify connectivity of the individual subregions. and determine whether there are differences that exist in epilepsy patients versus healthy controls. Past diffusion work in this subject has focused mainly on, exclusively on looking at the hippocampus as an entire structure. So this was the first attempt to try to quantify connectivity on a more granular scale. So we recruited 25 MRI negative epilepsy patients for this study, as well as 25 healthy controls. All patients were scanned at 7 Tesla field strength, and at the bottom you can see the 3 sequence parameters, or the 3 sequences that we use for the image analysis: the T2 TSE, the T1 weighted MP2 range, and then the diffusion MRI scan. These 3 scans were part of a larger protocol, but these were the three that were used for the image analysis in this study. And you can see here our list of participants and their suspected seizure onset. Again, it's suspected because these are MRI negative, and the neurologists cannot conclusively confirm exactly where their seizure onset is. However, they can give their best approximate guess based on EEG and semiology. So to perform the hippocampal subfield segmentation, we used the newest version of FreeSurfer, version 6.0. It was a multispectral segmentation, so it used both the T1 weighted and the T2 weighted scans. And you can see here the segmentation is overlaid on the T2 weighted imaging, which had the highest in-plane resolution, which was 0.4 by 0.4 0.4 by 0.4 millimeters in plane, which we believe allowed to give a very accurate delineation of the subfield boundaries. In A, you see it's an example of 2 coronal slices and 1 sagittal slice for a healthy control, and in B, the 2 coronal slices and then the sagittal slice for a patient with suspected left temporal lobe epilepsy. So here is a schematic of the workflow for this project. In A, you can see the B0 diffusion image, which was used to perform constrained spherical deconvolution and obtain the fiber orientation distributions, which you see in B1 and B2. These fiber orientation distributions were used to perform probabilistic tractography, which you see in C. In the bottom row, you see D is the structural T1 weighted scan, which FreeSurfer used for a 5 tissue type segmentation, which allowed us to find the gray-white matter border, which you see in E, which was used to perform the anatomically constrained spherical deconvolution and probabilistic tractography. In part, the T1 was also used in F to perform the hippocampal subfield segmentation, which was inserted into the whole brain tractography to yield structural connectomes, which you see in H. So the degree of connectivity of each subfield was found by taking the total number of streamlines or fibers going into or coming out of each subfield to give an overall measure of connectivity of the subfield. Additionally, fiber density was calculated by dividing the degree of connectivity by the subfield volume to give fibers per cubic millimeter. And the degrees of connectivity and the fiber densities of the total epilepsy group, the temporal onset group, the left temporal onset group, and the right temporal onset group were looked at independently and compared to those of healthy controls. A false discovery rate adjustment was applied post hoc to account for the issue of multiple comparisons, and we considered any finding below a p-value of 0.05 after the false discovery rate to be considered significant. So you can see here were our findings for the degree of connectivity. In the left hemisphere, we found within the left temporal onset group that the presubiculum and parasubiculum showed increased connectivity compared to healthy controls. And in the right hemisphere, the entire right hippocampus in the entire epilepsy group, the temporal onset group, and the left temporal onset group all showed reduced connectivity. And within the left temporal onset group, the right subiculum and the right CA1 also showed reduced connectivity. So the general pattern we're seeing here is increased connectivity ipsilateral to the suspected seizure focus in left temporal onset patients, and reduced connectivity contralaterally to the suspected seizure onset zone. So here are the fiber density findings, which mirror the degree of connectivity findings. Again, in the left temporal onset group, we're seeing increased connectivity in the presubiculum and parasubiculum. However, we're also now seeing it within subiculum, CA3, and CA4. And within the entire epilepsy cohort, we're seeing increased connectivity in the the left presubiculum. And on the right hemisphere, we're seeing reduced connectivity in subiculum, CA1, and whole hippocampus. Again, this is the same pattern as the degree of connectivity, of increased connectivity ipsilateral to the suspected seizure focus and reduced connectivity contralaterally. Here's a 3D rendering of the tractography that was performed in this study. In A and B, we have the whole brain probabilistic tractography. In C, we have the 3D bilateral renderings of the hippocampi. In D, we have the streamlines coming out of the whole hippocampi. In E, we have the hippocampus with CA1 delineated. In F, we have the streamlines coming into and going out of only CA1. And in G and H, we have, again, CA1 and bilateral fibers coming into and going out of CA1. So in summary, we found increased connectivity of the subicular regions in the left temporal onset patients. Interestingly, the subiculum is the main output gate of the hippocampus. So it's plausible to believe that hyperconnectivity of this specific brain region may underlie hyperexcitability of the hippocampus and may play a role in seizure propagation in patients with left temporal onset epilepsy. We also found reduced connectivity specifically in the right CA1 and right subiculum in patients with left temporal onset epilepsy. Past research has shown that neurons in CA1 are particularly susceptible to seizure damage. However, there are other areas that are also susceptible to seizure damage, such as dentate gyrus, that we did not see an effect in. So future work will be needed to corroborate those findings, as well as to explain the overall finding of increased connectivity ipsilateral to the seizure focus and reduced connectivity contralateral to the seizure focus. However, the main takeaway point from this is that despite normal appearing clinical scans, these MRI negative patients did appear to show abnormal connectivity within some subfields of the hippocampus. And in conclusion, high-resolution diffusion-weighted imaging may be useful in evaluating these cases with difficult-to-localize seizure onset zones. Findings from this study could be useful in seizure hypothesis and also for planning intracranial monitoring and placement sites for SEEG depth electrodes. It could also be useful for surgical resection of epileptogenic tissue and may help preserve non-implicated regions of the medial temporal lobe in patients with cryptogenic epilepsy. In the future, we will need to validate these findings with a larger sample size. One of the main issues of this project was after we divided the patients into seizure onset groups, we had very low sample sizes, and that could have prevented many of our analyses from reaching statistical significance, especially after the false discovery rate correction was applied. Additionally, we will also be looking at measures of microstructural integrity, such as fractional anisotropy and mean diffusivity, to create a more comprehensive picture of connectivity changes that may be occurring in these epilepsy patients. And lastly, this methodology may be useful in studying other diseases where the hippocampus is implicated. And in particular, we are applying this hippocampal subfield-specific tractography to major depressive disorder. So I would like to thank Camille Bannabaker, Dewey Chu, and Rima Fayed, who help with the scanning and the scanning schedule. I would like to thank the collaborators of this project, and I would also like to thank my mentors, Dr. Zahi Fayed and Preeti Balchandani, for letting me be a part of this exciting research. So thank you very much.
Well done, Jack. We'll take some questions, and please use the microphones.
Hi, very nice talk, thank you.
Thanks.
I was just wondering, were the clinical reads done on 3T or were they done on your 7T?
They were done, sorry, which clinical reads?
To determine that they were MRI negative.
Good question. So they were MRI negative based on their clinical scans, which would have been done at 1.5 or 3T. And their 7T reads we actually looked at in another project. So in the slide that I was talking about of structural focal abnormalities, there were some cases where we detected some sort of abnormality in the cortex or vascular abnormality, but those abnormalities weren't evaluated in this project.
I see. And then just one more quick one. Did you look at hippocampal volume differences, whether control and ICV corrected? Because with TLE, about a quarter of the patients tend to have MRI negative, but you have MTS in a bunch of them. Mm-hmm. So you can have these kind of confounds there, and there's a lot of interesting literature regarding that. And I was just wondering, because you have you're running free server 6 on it and the nice hippocampal subfield analysis.
Yeah,
So.
that's a really good question. So the volumes were calculated for this study. However, the analyses weren't performed on the volumes, particularly for the fiber densities. We think that a couple of our fiber density findings, I reported increased connectivity in CA3 and CA4 fiber density, and that could be driven by reduced volumes in these subfields. So that could.
We're doing another paper on that.
Yeah, that's a current area of
That's a different
investigation. But good question. Yeah.
All right.
All right.
Well, thank you very much, Jack. And this is for you.
Thank you so much.